My talk, Santhan Gopal, must be loaded there. Did you get it? No, not that one. No, yaar, squint, Santhan Gopal. They deliberately did something wrong. There, Amblyopia. Okay, how many of you are postgraduates here? Okay, a lot of them. Please take the QR code from the boy there. He will give you and copy that onto your QR code and get it on your email. All the details you will get about this instrument I am going to talk about. See, amblyopia, everybody knows, is loss of vision of two lines in one eye compared to the other eye. That is, definition has been going on for a long time. And we are amblyopic to what exactly has been the progress. Because we are happy. Somebody has defined, we will continue doing the same thing. Why bother about worrying about it? Now, old definition is difference of two lines. Is it really the amblyopia? Amblyopia is associated with a number of other defects, like the contour interaction is wrong, the counting difficulties are there, hyperacuity difficulties, so many difficulties are there. And if you just say amblyopia is associated with difference of two lines between the two eyes, it has no meaning at all. So we need to change the definition of amblyopia. Now, how do you change the definition of amblyopia? You need to know the etiology of amblyopia. And you need to know where is the problem in amblyopia, then only we change the definition. There are basically four types of amblyopia: strabismic amblyopia, anisometropic, high ametropic and visual deprivation amblyopia, and hyperacuity disorder, shape perception, spatial interaction, and contour integration, visual counting, reduced or absent stereopsis, and motion processing. All these features are abnormal in amblyopia. How do you explain them? Just saying two visual line difference between the two eyes has no meaning at all. So we need to explain all these things properly in amblyopia. To do that, you need to know neuroanatomy, neurophysiology, neuropathology, and also you need to have all the other ophthalmic skills, not just this knowing neuroanatomy, etc. Okay, sorry, it went. Okay, vision is a very complex process. It has got dichotomous process, nasal and temporal retina, right and left eye. Then at the lateral geniculate body, you have the vision going into, oh yeah, something wrong. Okay, I'll keep my finger on that downward arrow. There's no light here. So at the lateral geniculate body, you see the central retina has a greater representation in 3, 4, 5, 6, whereas peripheral retina has a smaller representation in only layers 1 and 2. Again, there is a crossing of nasal and temporal. Nasal crosses, temporal doesn't cross. So these are all dichotomous processes which happen in the brain for vision. Now, if it didn't happen, then we would not have had binocular single vision at all. Now, in the brain, again, it's so complex that you need to time to understand and read. That is what the QR code will tell you in detail. That I asked somebody, where are you from? She said, I'm from Hyderabad. Okay, where exactly in Hyderabad? Well, which city, which street, which house number, etc. So in the brain, if you say amblyopia is associated with problem in V1, okay, where in V1? Is it associated? V1 has 6 layers, 1, 2, 3, 4, 5, 6. Again, layer 4 has 3 layers, layer 4A, 4B, 4C. Again, 4C has 2 layers, 4C alpha, 4C beta. Now tell me, where is the problem in amblyopia? The moment you ask that, everybody gets completely and thoroughly confused and they keep quiet. They don't ask me any question beyond that. So I am also happy not answering many questions because I myself am amblyopic towards a lot of things in amblyopia. Okay, LGB is not a simple relay station. Why am I telling you all these things? You stop me exactly. I don't have the timing. I can't even see the timing here. You stop me when I'm 15 minutes or 16 minutes because I started 1 minute late. Why am I telling you all these things? Because the machine I'm going to show you is going to make a lot of difference to treatment of amblyopia, and it is no longer patching. I don't patch any of my patients for amblyopia treatment of any type. Okay, in the lateral genital body, it goes to the layer 4C beta and 4C alpha. P cells go to 4C beta and M cells go to 4C alpha. That is the dichotomy in the vision which I am trying to point out. Okay, again, once it reaches the brain, every object has 4, 5 or 6 features: shape, size, surface, texture, color. Position, movement. An object may be moving towards you or object may be moving away from you. An object may be of particular color, texture, shape, size, etc. And these two are again separated into two different parts. Position and position and movement are by the supraparietal area, whereas the shape, size, texture, color, etc. is by the inferotemporal cortex. You see the dichotomy, how the vision, this is, see, if God had decided like the traffic condition in all over India, your brain would never have worked. And he has regulated it so beautifully that everything works properly even if they don't have brain. Okay, so let's move on to the next one. 6 layers, I have already told you. Layer 4 has ABC and C has again alpha and C beta. In alpha goes the movement and position of the object, and beta goes the other layer, other aspects of the subject. Now right and left eye are segregated again in layer 4C, alpha and beta. The right and left eye are completely segregated. The right eye doesn't know what the left eye is doing unless the brain intervenes. You understand? They go ultimately to the binocular single cells situated in level 4A, 4B and 4C. Till then, they are uniocular. Above that and below that, they are binocular. Okay, that is important to remember. And without the binocularity, you will not be very successful. Okay, let's not go to that. This is how the brain connection with the eye looks like. This is called Sarvendriyanam Nayanam Pradhanam. This is what they said 4,000-5,000 years ago. Now, why did they say that? Do they have brain? Well, they had brain, and you can see here how the brain from the eye is interconnected in various parts of the brain. And to realize that if of all the afferent impulses, 40% are from the eye. Afferent impulses that go to the brain, 40% are from the two eyes. And from the rest of the body goes the remaining 60% of the impulses. So therefore, eye gives you a lot of information about the brain of a person if he has, and about the abnormalities of the brain of the person also. Because you can diagnose psychiatric disorders also by looking at some psychiatric abnormalities. If there are some psychiatric abnormalities, you know that there is some psychiatric problem with the patient. Okay, tumors and all you can easily diagnose. So now, board scan shows that in amblyopia there can be some problem with the blood supply of the area when the eye is looking at the object has amblyopia. Okay, that side of the brain is not working or is working less. So even PET scan does the same thing. So one small eye, you can see how it can cause vast changes in the brain if it does not send impulses to the brain properly. Is eye subservient to the brain or brain subservient to the eye? Both are equally important. That is why we do not differentiate between eye and brain. We call it as retinocerebral apparatus. We are together, they are together. Retinal is not necessarily separate from the brain. And brain cannot function without the eye to an extent. But eye cannot function at all without the brain to any extent. But brain can function and compensate for the loss of the eye in the very early age by diverting information from the eyes towards the ears and other sensory organs. And it happens, I've seen so many children who are completely blind, but they can easily walk around because they do the echo as the, tell me when I'm, don't hesitate, please tell me if I'm, how many more minutes there? 5 minutes over there. Okay, so eye can have significant effect on the brain. In the same way, brain can affect the eyes also. Okay, which you have seen. So for a complicated problem like amblyopia, we have been saying, oh, patch the eye. That's it. Nothing needs to be done. Do you think it is correct? Do you think you shouldn't we utilize all the other knowledge that we have obtained from cutting edge technology like FMR, bolt scan, etc., DTI scan, MRI, different varieties of scans, etc., to find out where is the problem in amblyopia and treat it properly? By patching one eye, you are assuming that the amblyopic eye will focus. Not necessarily. It need not focus because the eye is controlled by the brain. In the brain, the eye is controlled by the attention center in the parietal lobe. So the problem in amblyopia is in the parietal lobe. Everybody will be shocked if I say the problem in parietal lobe and frontal lobe in amblyopia, then they will say, what is he talking about? For that, you need to read the QR code, and in that, everything I have explained. Okay, so to prevent and treat amblyopia, we have devised a new technique called orthoptic. He will show you the machine also. Sorry, where did it go? Yes. He will show you the machine also after the lecture. And what it does is it stimulates the peripheral retina first. When you stimulate the peripheral retina, the information goes to the parietal cortex first. Even before the central P cells send impulses to the 4C beta. The 4C alpha would have already sent the information about peripheral retina to the attention center. So the attention center is grabbed first by the peripheral retina. But then the central retina grabs the attention center a little bit later because it has to go to inferior temporal cortex and then come back to parietal cortex. So there is a gap of a few. Don't think that it takes ages. It takes only a few milliseconds gap that is good enough for the brain to understand. So the brain knows exactly where the eye should see, even before the eye has seen. This is what I'm saying. Eye has not seen the object and analyzed, but the peripheral retina has already seen and it knows where it is. So it tells the central retina, move the eye to see that fellow. And when eye moves. When the eye makes a saccadic movement, the retinal suppression happens in between the fovea and the peripheral retina. That area is suppressed. That means 2 points are stimulated in the brain. The peripheral retinal point which we have stimulated and the foveal point which needs to be stimulated. Because as the eye moves to take a fixation, the fovea comes into fixation, it gets stimulated. So this is the principle on which we have based the machine. This machine treats amblyopia in majority of the children in less than 15 days. Younger children, 4 5 years old children, if you use it in amblyopia, in 4 days the amblyopia disappears. Whereas up to 55 I have treated amblyopia and it does respond. So what about the plasticity, somebody asked. There is nothing called plasticity in this particular thing because it depends on what is called as top-down impulses coming down from the parietal lobe to the occipital lobe. Every time the eye moves to take a fixation, the top-down impulses come from the parietal lobe to the occipital lobe. Occipital lobe is a simple forwarding center. It just obeys the orders of the higher center. I call occipital lobe as Manmohan Singh. He doesn't do anything. He just follows two leaders who are there at the top. Whatever they say sit down, he will sit down. Stand up, he will stand up. But he is important because he has to transmit those orders forwards to the infratemporal cortex and the parietal cortex. So I call occipital cortex as the Manmohan Singh, infratemporal cortex as the Sonia Gandhi, and supraparietal cortex as Rahul Gandhi. So with this, I stop my talk. I think I'm almost through. You can collect the QR code and copy it. You will get all the information there about the machine, how to buy the machine. And in Delhi, we have Center for Sight, present President Harvansh Lal and Sudhang Bharti have bought, and many places in India, over 85 machines have sold. If anybody interested, he will show you the machine also. Thank you very much.
Uh,